Hi, everybody. Welcome to Pre-Hospital Paradigm Podcast. Sorry about the delay. As you can imagine, when we're on the road, sometimes it's difficult and we have to overcome some hurdles. So tonight we are live from Cleveland EMS Headquarters with Sharon Kozel and Kim Florczyk, who are both sergeants of education. And we're going to jump right back into where that last episode left off. So I know you guys have some special guests in the audience tonight, so maybe you want to introduce them too.
Go ahead.
Okay. We have our medical director, Dr. Escajeda here. We have some field personnel. We have Commander of Education, Nick Sayer, and the Commander of Operations, John Worsler.
Awesome. Thanks for being here.
And we're excited for you guys to be here live
Good.
and to talk with you guys again. We've been doing good stuff since the last time
Yeah,
we
let's hear about it. What else is new? So when we were on the episode, you guys were just pretty heavy into blood product. So how's that going?
The blood program is still going strong. Right now, we've given blood to 57 patients total. We have some data off of 50 patients that I have here. So for this data, we excluded the traumatic. We gave it to traumatic full arrest, and we excluded patients that we didn't have all the data for. So that left 35 patients. So out of 35 patients, 29 were discharged. So 83% discharged from the hospital.
That's awesome.
Yeah, it's good. Really
Out
good.
of all of those 39 cases, were there any issues with the actual administration or setup or?
Not that I know of. I don't think there's actually, the crews are really excited. They have been through extensive training. The captains have been through extensive training. And so far, there hasn't been any issues with actually giving the blood.
What have been your issues, if any?
I haven't heard anything.
Yeah, I personally, anyone else in the audience have any issues? I don't think there has really been any issues.
Do you notice like maybe a delay on-scene transport times waiting for blood product, or are those supervisors there really quick? Like,
Yeah, I think they're communicating really well, so that the supervisor and the crew communicate. Commander Worsler, he wanted to say something.
Sure, I can comment on that. Our times are up slightly. We aim for that 10-minute window. We are around the 12 to 13-minute mark. But the important thing is, thinking about that short delay is the benefit that the blood presents to these patients that may not even make it to the ED to start with. And in addition to that, giving this blood in the field actually reduces the amount of blood that's being given to these patients inside the hospital fairly dramatically. So a little bit of extra on-scene time, very minimal, and we're seeing a lot of positive outcome from it.
And the way your system's set up is you've got blood products in chase vehicles or command vehicles, not in every ambulance, correct?
Correct. Yeah.
So chase vehicle, command vehicle goes out to all those traumas, right?
Yeah, they're
Yeah.
dispatched to anything that may require whole blood. I was on the truck this weekend and we had something and the captain even got there before we did, and we didn't have to give whole blood, but they respond pretty quickly. So.
Yeah, so right now the protocol is set up for traumatic hemorrhage. But the next update that comes out of blood, the next update will be for medical hemorrhage, which will expand it huge. So we give it a lot over the summer during like our trauma season. And then it kind of dies off a little. Like we haven't given it as much as we did over the summer months, but that might change when we start giving it for medical hemorrhage.
sure. That's pretty cool.
So-
How many supervisors are carrying it?
There's three captain's vehicles right now.
Gotcha.
And how many units does each vehicle have on it?
2.
Okay. Do you guys often give 2 units, or so are you giving them one at a time? Or are you doing 2 large bore IVs and bilateral arms?
Yeah.
2 units? How are you guys doing it?
I don't know how often they give. I think they
3 times?
3 times is when they've given it twice. So 3 times they've given it twice.
Okay. I mean, it's fantastic. I mean, I sit on the bi-monthly meetings that we talk about it, and they're just phenomenal numbers for success rates you guys are having with whole blood. And everyone's kind of looking, one of the big things in EMS now is looking at how do we get blood to people. You guys sadly have a need for it, obviously, with your patients. But part of why we want to do this is, especially my med command is a very rural area as opposed to you guys are downtown, 100% urban, 100% of urban problems, whether that's traffic or different medical calls as well. So what, I guess on the thing of like new and exciting things, anything else new and exciting you guys are working on since we last talked in November?
Vents. So we got vents the day before we did the very first podcast. And I know it had been used within a few hours for BiPAP, and people were just amazed.
That is something I wanted to say. Like, it is so cool to me that you guys can introduce something and very quickly get results.
Yes.
Whereas we might introduce something and it might be a month or two to trend something. But I mean, we were talking earlier, like it's really quick.
Yes.
Like,
Well,
so your
people-
vents, like you introduce them and you've already.
Right, like blood was within 4 hours it was given, you know, twice in the first 12. Vents the same way, and I mean, our field personnel are really excited about having vents. I know I got the pleasure of using it. I was right in the field. It was a trach patient. We were able to just mimic their settings, which was great, and we had a respiratory therapist on scene, and it just was so smooth for the patient, and I really liked that. So, but Commander Sarah could give you a little bit more statistics on that. Unfortunately, Sergeant Moyer couldn't be here today, and he's our expert vent guy.
Sure.
So.
Yeah, so when the vents got deployed so far to date, we have 66 runs where we use vents, and we've used vents concurrently with ketamine 11 times. So right now we're seeing, and that's for invasive. So whether they have a secured airway, some sort of advanced airway, and or a trach patient, mostly is what we're seeing here for the use of the vents. We also have it as bi-level or BiPAP and CPAP. All of our vents at the current state is going to be for 16 and older is what we're looking for. And that's because of state scope of practice, although that did just change recently. I think it was November, December, it did just change because the technology is sort of outpacing
The law.
the law and literature and how much it needs to be updated. So we were talking with the state medical director, and I know a couple other departments also had the same questions or similar questions based on can EMTs operate vents, but within their scope of practice, not advanced settings, but using CPAP or BiPAP and within their scope. So they changed that recently, so our protocols will get updated to reflect those changes. But right now, we've used events 66 times.
That's phenomenal.
Yeah, with with good outcomes.
So I know we talked a little bit off camera, but how long have you been with Cleveland EMS?
Approximately 20 years.
And all of a sudden, I see that you guys have just like, you're doing all these really cool skills. Any reason for that?
Yeah, leadership change. We definitely had a big leadership change, top down. And it's been a real growth mindset instead of, I don't want to say stifling, but going with the status quo. You know, one way to kill progress, I always think, is always sticking with the old adage of, well, that's the way we've always done it. And so far, this leadership has looked at that and challenged it, and what can we do to get better? What kind of people can we put in place to make the division better? And with that type of leadership and growth mindset, we do look at the state scope of practice, and sometimes we also contribute to trying to change that. We write to the state medical directors, go to the EMS board, see what we can add, and how can we change pre-hospital, not just for us, but for any department or division across the state.
I feel like that's got to help your retention too. I mean, coming from the fire side of things, I'm one of the rarities that I'm on a firehouse, yeah, but I like the EMS side more than I love both, don't get me wrong, but coming strictly to Cleveland EMS, you're Cleveland EMS. And so to have something that finally pushes you guys to advance, and all of a sudden these new techniques and stuff, that's got to help. Like,
Oh, huge. So under the last administration, we were consistently having approximately 45 to 50 people leave a year for various reasons. I don't want to say it was because of leadership, because that would not be fair. But I will say under new leadership and with all the advancement that we're doing, we're at about 25 people a year, so that's almost cut in half, and we're keeping people around longer. Before, your average career here was about 5 years max, and now we're having people here retire here, which on a consistent basis, which is always nice to see. And their family members are coming in, their sons, their daughters, and other family members are applying now, so that's also nice to see.
I keep telling my kids, don't do this.
Yeah. Get away. No, they're like, come on, let's work.
Go somewhere you make money, right?
Yeah, so it's good.
No, that is fantastic. What do you guys see coming? Like, what's in the near future? Are you going to continue to advance?
Always. We're always pushing limits. Commander Wursler, myself, Dr. Escajeda, the other leadership here, we're always trying to see what we can do next, better, bigger, what advancements we can make within the city to serve the citizens, but also pre-hospitally for the profession in general. Yeah, like we have a community outreach program right now that we're starting to build. We just posted for a deputy commissioner for that bureau. It's going to be its own bureau. And so right now we've had it developing, I would say, 6 to 12 months. And we have a harm reduction specialist, and she's already administered or given out over 500 Narcan kits. We reached out to over 700 people, tried to make contact with them. The hardest part about that is actually making contact. If you can imagine, some of these people don't have consistent cell phones, numbers, ways of contact, so we have to try to get a hold of them the best way we can, and it's not always easy. We've helped somewhere around 106 to 110 people and bridge that gap for services to refer them to the different, whatever they may need, whether it's heating, cooling, home repairs, or medications, setting them up with a PCP. And then we have a group or a team that's going to go out and start doing home visits, evaluations, and trying to reduce 911 use. Not saying that, I don't want to say abuse, because they're not abusing it. It's what they know, and they need help. They just don't know how to get it, so that's why they call us, and that's what we want to deliver that service without stressing the 911 system.
Yeah, that's cool. That's phenomenal.
So one of my community paramedicine programs, for every 100 calls they go on, they'll see a 33 to 36 call reduction. So going 100 calls, 100 in-home visits, 1/3 reduction. So if you have got a bunch of people, you do 1,000. If you get a reduction of 300 calls, that's one call less a day. That
Right.
makes huge changes. It's a huge relief.
But
to you guys.
positive changes.
Oh, yeah,
It isn't like you said, and it's not about the call volume per se. It's just, I mean, to make that type of a positive change in somebody's life and their lifestyle and their well-being, I mean, that's taking the advocacy above and beyond. That's really cool.
Yeah, and we're hoping not only for the call reduction, but to actually, like you said, hit on it, help that person, that individual in that moment, in that time, so they have just an overall better environment to live in. They feel happier about themselves and their health moving forward. And hopefully we can also reduce the stress on the 911 system, but also the emergency rooms too. So
Yeah.
we have, multifaceted goals that we're looking at.
And it's sad that that's not in the news. You'll see that squads are breaking down or this or that or the 911 response times, but it's never like this. And it's like that needs to be pushed. Like, that's really cool.
Yeah. Yeah, and as soon as the deputy commissioner for the bureau gets announced, whoever that may be, I'm sure they're going to take it and run with it and try to grow it as much as they possibly can. Public safety will help oversee that, and there's codified ordinances in the city right now that will also mandate its use and its structure. So it's not something that we just want to do here at EMS. It's something that the city also wants to do, the city leadership. So they believe in it so much that they put it in the codified ordinance. So.
What about the boots on the grounds, like the older population of your employees? Are they all for it too?
I think that they're for anything that's going to help the patients.
Yeah.
I think that I don't want to say the resistance to change, but changing certain things and aspects of the job will be different for them. But once they see the outcome for the patients, or they're not seeing an individual person so much, I think that they will be more inclined to accept it. We have very open personnel that are willing to accept a lot of change, and we've thrown a lot of change at them in the last 2 years, and they've adapted really well. Really, I was surprised by it just a little bit, but after the first one with the ketamine, when we did the ketamine rollout, and then they started to adopt it, and they started to use it appropriately, and then we did vents, and then we did blood, then we did vents, and now we're doing this, and we have some more stuff coming, but every day it's something new.
I think that just takes above and beyond a good provider. Like they're in it for the good stuff. It's like,
Absolutely.
that's cool.
Yeah, I want to just, on top of that, not only do we have a community outreach, we have a community education program here too. So they do all the CPR classes for the city. They do Stop the Bleed, which is great. We're putting all the boxes for Stop the Bleed in all the city buildings around once that's done. And they also go out and do health screenings. So they do over 3,200 screenings for our citizens, which is great. So blood pressure screenings and all that. So that gives them a lot of information. So we do a lot.
And I know you guys have an event coming up too.
We do. We're having a dodgeball tournament on May 30th. This is our 3rd annual dodgeball tournament. All proceeds go to our peer support group, which is fantastic. That helps with training new members, continuing education for the members that we have. We currently have 22 on our peer support now. We keep a chaplain and a mental health professional on at all times. And the nice thing for us is we do a lot of our communication with our peer support in real time. So we have field personnel, we have some captains that are involved. So if a critical incident happens, we can get that paged out in real time, and then we can actually go ahead and contact them quickly, or as soon as we can, which is fantastic. So maybe, Sharon's available that day. Sharon's also peer support, so maybe Sharon's available that day. She can do it, or I can do it, so it's nice.
And your academies, are you seeing more enrollment?
Yes, we just graduated an academy last month, and we're about to start a new academy actually Monday. It's going to be a little bit smaller, but we're retaining the ones that we're getting, so that's pretty fantastic. Anything to add on the academy?
We're getting more people. This last academy, we had more people apply than the other safety forces, like the other safety in the city.
Yeah, it was
I
over
think we had-
200?
Yeah, I think it was close to 300, right?
Wow.
People apply for EMS, and that was unheard of for a long time.
When we're doing great things, people want to come here.
Absolutely. Why wouldn't they? So how many stations do you have?
20, yeah,
We do 25 units during the day.
and 21 at night.
Yeah, if it's fully staffed, 25 during the day, 21 at night.
And then how many did you just have over St. Patrick's Day?
We have special event units too. That we have little mini ambulances.
I just
so
saw
on
the one I
special.
walked-
Yeah. So on the Browns games or different holidays, we'll have the little minis going around and extra units if we can.
Sure. What is that, an ambulance for
Yeah,
nuts?
those are fun. The little minis are fun.
Commander, how many stations do we have? Do you know offhand?
We have 25.
25? Okay.
Yeah, we have 25 now with our upstaffing. We're almost at max capacity currently inside the division. So there are times where we're able to run 26, 27 units during the day or 22, 23 at night. It just really depends. You know, obviously you have call-offs, you have benefit time, but you know, building on what Commander Sayer was saying with the change in atmosphere around here has also brought us the ability to staff our squads appropriately and potentially grow here in the future as a division as a whole, grow our numbers out and continue to grow these other programs. So yeah, I think we're moving in the right direction.
Remind me, your staffing of your ambulances, is it 2 providers?
Yes.
Okay. So if you guys have a trauma call out or cardiac arrest, what resources go?
Fire will come.
Okay.
So we get a first responder. So we are either 2 paramedics or an EMT and a paramedic,
Plus
plus fire.
chase too.
Yeah, so the captains will also respond. And then we have 4 ALS fire units throughout the city. So you always hope you get the one with the paramedic on it. Not always the case. But yeah, and then fire can drive to the hospital for us, or we can have one in the back helping out.
So is that often the case that for your critically ill patients, right?
Yes.
Is that often the case that fire will hop on as a driver and then you've got 2 in the back for care?
Yes.
Or 2 more?
Yeah. I mean, 3's enough. You really can't have more than 3. There's not room for more than that back there.
No,
Everyone's
it
kind of
gets a
getting
little tight back
It's a little crowded.
I'm glad a couple of my students, Scott and I, students from the medic class, they said that they rode with you guys, and they were just like,
Yes.
they're like, we learned a lot. I was like, and I encourage you guys to all go there and
Yeah,
learn a lot.
I go and I try to talk to all the classes before they come and ride to kind of give them an idea of what to expect. But yeah, it can be an eye-opening experience for some
the one
people.
kid was like, I'm so glad she said bring something to eat, because we didn't stop. I was like, she said bring food.
I did. I told them, bring a change of clothes and food. So he listened to me. They listened to me.
Yeah, I think. What else you guys want to add?
I know one thing we're doing new, I don't think we talked about, the last one was the NALS, the Neonate Advanced Life Support.
Okay.
I don't know if we talked about that.
I think we did.
So we just recently, our education staff and Commander of Education were certified as instructors for Neonate Advanced Life Support. And eventually, we're going to be teaching the field. Statistically, we have a high infant mortality rate in the city. So this was something the commissioner was very passionate about. So we're pretty excited about that. We're working to get the equipment that we need and to bring it out into the field. So.
What kind of a special equipment are you guys getting for that?
Well, we're going to need the mannequins to teach,
Sure.
all that.
Do you have like hand heavy bags, or what is the?
No, so we don't have hands heavy bags. What we just carry our Braslo kits right now. But for
never heard of
neonate advanced life support, what we
I don't know what that is.
plan on doing is getting a neonate response
too?
bag or a newborn bag for those types of patients. Anyone who uses a Braslo kit, they know that is the equipment doesn't go down small
No.
enough, right? So we need to make sure that we have equipment to treat these patients when that event does happen. I mean, I think statistically 80, 90% of the time all deliveries go well, but for that small percentage of time, we want to be ready for that. And because of what Sergeant Florczyk was talking about with the community and having a high mortality rate, unfortunately, or complications during delivery, we wanted to make sure that our crews were comfortable handling those types of calls. So that's why we reached out to American Red Cross for the NOWs, and then we're going to be going ahead and we're going to be teaching that so that we can have the education that we need. And as far as the equipment goes, we're going to try to get all different stages of development for a potential newborn, so when they're delivered. I know some of the toughest calls for people are deliveries and when they go wrong. Sometimes visually, it's a shock to the system when you see a 24-week-old baby that is delivered and you're not sure anatomically what they're going to look like. So that shock of the system. But so if we can prepare them for that without scaring them and getting them ready for how to handle that and go through that call to provide the best care, they'll also, not only will the patient have the best outcome, but the provider too afterwards, not second guessing themselves. What did I do? Did I not do this right? What's the calculations? So helping them prepare for that will also help the provider in the long run too, mentally and emotionally.
Yeah, we actually had Dr. Ariel Oliker did a neonate series for us once, and it was phenomenal. And some of the differences and anatomically was vastly different.
Even their tidal volume. Right?
Yeah.
Like we sample end-tidal CO2 more than what a neonate can breathe, which is just insane.
Yeah, I remember that. That was crazy. Crazy. I think somebody had mentioned drones. Did I hear that correctly?
Yeah. So Cleveland EMS is working with fire. It's just a test right now. We have 2 pilots. And me and Commander Wursler talked a little bit today. They're flying 10 hours a day, and they're responding to like house fires, highway MVAs. If you want to add anything more to that, Commander.
They're bringing lunch to certain firehouses.
Right. Yeah, everyone was really excited about the drone thing. So the 2 people that we have that got drones, I'm like, we need a name for you. You need a flight suit. So, right.
Aviators.
Right.
Right now, it's a beta program. Just got started up through the Department of Safety inside the city. There's 4 Cleveland firemen that are part of the drone program, as well as 2 of our paramedics. Basic response right now, highway accidents, house fires, stuff like that, while they're testing out the system and making sure that the pilots, earn their wings, so to speak. And then I think the end goal is to expand this out. If this beta goes well, they're going to be putting more drones throughout the city and hopefully being able to touch all 4 corners. And then that'll also expand the program as far as potential pilots. So it's very much in its infancy. As a matter of fact, last week is the first time that drone went up. So it's a lot of little baby steps right now, moving towards a lot of big future potential. What that looks like, I couldn't tell you right now, but we have some ideas of how to use it, Commander Sayer and myself, and we're going to be trying to push the envelope like we are on everything else.
So I want to call it a question from online. I'm assuming it's someone that works here. They just said, when I asked them for questions, they said RSI and IV antibiotics. So I'm assuming that this is new stuff that's going to be coming.
Dr. Escajeda.
Hey,
Hi.
hi. Sorry for coughing. We do not currently RSI. We do not currently administer IV antibiotics, but anything is possible. So we'll see what happens. The big issues here, right? And I think what you're hearing a lot of is us trying to match the needs of this population of citizens and how to best align with what their needs are. And so, our priorities are the things that we kind of discussed. But, there's always room for advancing, pathways for further credentialing or things like that amongst our EMS crews, which may include RSI in the future. Who knows? There's just so many different angles that we can go, and I'm still learning the system. I'm new in this role. I haven't been here for quite 9 months, and so it's going to take some time. Rome wasn't built in a day, but the team is so talented, and we're recruiting such a talented, patient advocate minded group of people that just makes this process so much easier, no matter what we do, whether it's community outreach, whether it's administering whole blood. So to answer that online question, we're not there yet, but maybe in the future you can see RSI and IV antibiotics. IV antibiotics would be the lighter lift for sure.
Oh,
but,
absolutely.
but it all has to do, and I'll hand it over to Commander Sayer from education. Any little tiny change that we want to make involves so much from the education office, and it's just a huge lift for us. And so, which may sound simple is, let's just administer IV antibiotics. There's already a regional protocol that has IV antibiotics. Obtaining the IV antibiotics, putting all of the crews through training is an expensive endeavor. It's an arduous process that involves multiple people. And if it's worth it for patients, we'll do it, but it's going to take some time.
So I'll say on RSI that we have some agencies within UH that does RSI. None of my agencies do, although I had a crash course in an agency to do RSI, which is a story for a different time. But Caleb's agency does RSI, and how often do you guys do it?
We've had it, 3 years now?
Yeah.
Once.
That's
But,
what,
I mean,
yeah, that's what we thought. I remember us
Did
talking
that
about
one
that.
time change a life? I mean,
Yeah.
Yeah, so I'm also medical director for another ground agency that does RSI. And there are different requirements that the state determines.
Well, that's the other thing is training's
it's a lot of training.
It's it's very nuanced. It's 100%, medical director QI, QA for each RSI case. So that's an enormous lift. And I'm lucky enough where I have a very talented group at my other agency, and there's 6 credentialed RSI providers with that group. And again, we don't really intubate all that often RSI wise, even though it's a rural county. But obviously for us at Cleveland EMS, our patient needs are a little bit different. Our access to hospitals is a little bit quicker, and any sort of change that we make is just an arduous process to train everybody to do.
Well, I mean, from a medical director standpoint, I get worried about the drugs that are already in the box, and every time I talk, I'm like, the most dangerous drug in your box right now is probably metoprolol, and they look at me like I'm weird. I'm like, no, that beta blocker is probably one of your most deadliest drugs that you have in the drug box. And now we're talking about giving paralytics to these agencies, and I mean, you have to control that airway after you give that paralytic. There's not a you better, it's you absolutely have to. That you own that airway. As soon as you push that paralytic, you have to obtain access, because that patient can no longer breathe for themselves. And standard now around here, rightly so, is going to be rocuronium, and they're not just down for 5 or 10 minutes. They're down for a prolonged time that you have to get some type of airway on.
Well, they're down way outnumbers their sedatives, so it's
There's that too.
Yeah, and we have drug-assisted intubation if we need it. We have ketamine. I gave Sergeant Florczyk a bunch of statistics on the ketamine if she wants to talk on that. But as far as the training aspect, even though we would like to push the envelope, just like Dr. Escajeda was saying, is it going to be beneficial for the patients, right? So anytime we start to do something, we need to do a needs assessment, and that's what we do. How many patients can we affect? Would it be effective even if we did do it? Then we do a cost analysis. What is the cost of this? What is the waste to this? Is this going to be beneficial? Can we train? How many? And the smaller departments, fire departments around, it's very easy for somebody to come in and do an ABC shift, train 20 people, where we're training 300 people.
Exactly.
And we're looking, and it is quite expensive to have people come in on overtime to train monthly to do these things. So we try to be selective on what we're doing and make sure we're training them appropriately. And then not only we go through the needs and cost assessment and then training, and then it's the QI side of it. Are they doing it appropriately? Can we follow up with that? Can we meet those demands? And we have to go through all of those processes along with, hey, it's going to go on the truck. Are they actually going to use it when we put it out there? And where are we putting it on the truck? Because some of these squads nowadays, they're packed to the gills with equipment. So when we're thinking about actual equipment, not just medication, but the vents, when we deploy the vents, where are they going? How are we storing them? What's the easiest access point? What is our recommendation to the crew so it's just not getting put in a compartment that they can never access during that critical call? So all of these things we do think about, just because we are a larger service, and like we hit on before, once we release it to the masses, it's going to get used, and it's going to get used most likely in a large number in a very fast percentage. And anything that we try to plan for in education or operations, saying, hey, have we thought about this? We have thought about this. I guarantee you within 1 week of letting something out of the bag, saying, hey, this is what we're doing, we will have 5 to 10 responses immediately. Have we thought about this? I had this call, this happened. And we're like, oh my God. We can think of 100 things, and then new stuff will come rolling in right away. And that's good. We want that feedback. But, we do our due diligence before we put something out to make sure it's going to be beneficial for the patients and also our crews. We also don't want to overtax our crews. There's already so much that they have to do. It's yeah, this would be cool to do, but is it actually needed?
yeah.
Yeah. So Dr. Escajeda just motioned.
Did you just say he just said fingers?
Right.
How we train.
Right.
For something that's super subspecialized, but we're doing it in
Sure.
a methodical kind of stepwise process with a beta test group, et cetera.
Right. So Dr. Escajeda just hit on finger thoracostomy. So it's something that we're going to be doing in the future. In the near future, we're going to be doing that. And just like blood, when we started blood took about a year to build. And finger thoracostomies at this point, we're up to about 6 months on the build time. Because we want to get it right. Is it in the state scope of practice? What's the national practice? What are we looking at? Who's doing it? What went right? What went wrong with those guys? How can we build ours? What's the needs assessment? How many people will this actually affect? Is this going to replace needle decompression, or is this going to be an escalated intervention? Needle decompression fails, then we go to this. When should you do it? Not do it.
What other tools do you need?
Right. What are the tools? What are the training? What's the number of hours of proficiency that you need? How many mannequin slices do you need to say, hey, you're good to go to do this on a human? Like all of these things we start to take into account, and then it's, hey, the review process. After you do it, and we have the indications, we have the procedure, what's the review process? Every one of these are going to have to get reviewed immediately, at least until we can show that we have a good positive outcome on these consistently. So then we have to go through that. So we are 6 months into just looking at that alone, and so that's going to be coming out hopefully before the warm weather comes out so that we can help do that. But we also want to take it on with a smaller group of people first. So we will most likely be training our field training officers first. You know, they're a specialized group of people. They're very dedicated to the job, and we want to give them the additional skills that they want and that everybody's asking for, but we also want to make sure we do it in a stepwise fashion. So do the field training officers do it appropriately? Right now we have our SWAT medics doing it first, and we're working with our SWAT medics to develop the program, and then it's going to go to field training officers, and then hopefully if everything's successful, then we can release it out to the field. But
Which has been a very, like, Matt,
So this is just like a kind of like a nice blueprint of how, you know, you can do these advanced things in a large agency like this. So, you know, we saw that there was a need. Obviously, the state scope of practice changed and allowed paramedics to do finger thoracostomies. And what better group to start training to do that than our SWAT medics? So we have 4 dedicated SWAT medics. So that's going to be our beta test group to figure out, to make sure that the training process is completely clean and patient appropriate before we roll it out to the larger group. So that's in process, and that's, I mean, just developing it has been fun, you know, and it's completely new. I mean, how many times has a paramedic had to make a sterile field before, right? Like never. So all of these concepts are brand new. And so we're methodically thinking through that process with this beta test group, which happens to be our SWAT medics.
Do you want the ketamine numbers? I know it was brought up, but so we've, since November 2024, we've given ketamine 417 times.
Since when?
November 2024,
Okay.
417 times. So we give it for our psychiatric patients, pain, for assisted, to innovate, so sedate the
Yeah,
patient.
it's a great multi-use drug.
Yeah.
It really
I
is.
love ketamine.
It's almost as great as Epi.
So another online question here from our favorite fire guy. How does Cleveland EMS train new providers to handle high acuity calls?
Ooh. In the academy, I mean, we train in the academy. We try to do as many scenarios as we possibly can. We've changed a lot over the years also, so we're adding more skills to it. We got demi-dose medications now, which is great. So they, you know, one of the big things is you learn medications in paramedic school, and then you go out and you barely use certain things. So when you're in a really high-stress situation, you don't know how to use that. So we do a lot of high-stress scenario situations here, and then, I mean, they get a lot of that out in the field with our FTOs on ride time. So we've increased the ride time, which is great too. So.
So explain that a little. So your FTOs are going with the squads randomly in training?
So when we have an academy, so the academy is now 10 weeks. So the first 3 weeks they'll be down here. They do all their classes, you know, BLS, ACLS, C classes. And then on week 4, they'll be in class for 2 days, and then they're going to ride 2 12-hour shifts. So we're giving them more ride time, which is nice. And then we have our FTOs, so they're trained. They have specialized training for our field training officers. They do some stuff on Platinum Planner. They come down. Sergeant Mangaw's in charge of that and does training with them and continuing education. So we have fantastic FTOs, so they get a lot of ride time.
So something we do for that, and we noticed it in the other academies, we wanted them to get more ride time. And so right now what we did is, like Sergeant Florczyk was saying, at about the 3rd or 4th week, you can run as many real life scenarios as you want, but until you actually get in front of a person in the environment with the adrenaline going and your heart rate high, nothing can ever mimic that. So by getting them out earlier with the field training officer on the calls in the environment to mimic what they're really going to go through, we can't replicate that, so we wanted to get them out. So right now, as the academy is set up, they have approximately 14 ride times built into their academy time. And that's 10 weeks. And so what we try to do in education is 50-50 training, 50% information dissemination, and then 50% skills. So by doing that, you also, I mean, I'm sure you guys all know, being in the field of EMS or medicine, that a lot of us are just kinesthetic learners, right? You have to be hands-on. You can say it 100 times, but until you actually do it, and then it clicks, and then you realize, okay, that's the little nuance, that's the fine motor skill. So by allowing them to go out with our field training officers, we are relying on our field training officers more than we ever did before, because yes, we teach the initial instruction, but we're expecting them, and they do, reinforce that in the field, and then add to it for the nuances of the call. So that's how we would train for the high acuity calls. And some of the training that we've set up before, it's, you know, crawl, walk, run, right? Like, let's make sure they know what they're doing. Okay, let's add a little bit more complexity to it, a little bit more, until like what I sort of like to call chaos training, where you're like, what is going on? I have 5 patients to account for, and, you know, sensory overload, there's lights, there's sirens, there's everything going on. And, you know, we try to mimic some environments, and we do that with our rescue task force training or active shooter training, where we have high stimulation training, and then also sometimes deprivation, where you'll be blindfolded and also have hearing protection on, so you really can't hear or see anything, but you're expected to do some things.
I would, not to be blunt, but I mean, you're kind of weeding out people who, at that point, maybe this isn't for them.
I mean, that's not our goal, is to weed people out.
Not your goal, but I think that if there was an issue, I think you would recognize it.
Oh, I think they recognize it.
Yeah.
They do recognize it, and that's not a bad thing, because this job is, not everyone's cut out for this
Right.
job. Mentally, they can't do it, and I would rather you come in, know that, than try to just keep pushing and pushing and pushing, and now you're really struggling with your mental health. We do see a lot of really bad things here, and some people just can't handle it, and that's okay. There's nothing wrong with that. That's not weak, in my opinion.
No, and that was kind of my lead into that question, was like, how are you dealing with mental health issues within your organization? There's more and more of a push at every organization now to
Yeah, absolutely.
encompass that. So what is Cleveland EMS doing?
So we have our peer support, which is fantastic. That started back in 2016, I believe.
It's almost like you read this guy's question.
Oh, somebody just posted that?
So how do you support provider mental health and resilience?
Okay, so again, our peer support started back in 2016 due to a significant call that someone who was on. I'm not going to call out their name here. And then I was tasked, along with my coworker Danielle, to run the peer support, which is fantastic. So again, I said earlier, we reach out as soon as we know. We have EAP, we have Ease at Work. We work very closely with Dr. Franklin. She helps with peer support. And then now we are currently working on a mental health wellness program throughout all of our service. We went to a mental health conference a couple months ago, trying to find some resources. We have somewhere else we're going tomorrow, and Commander Wursler could be better to elaborate.
So, as we all know, for a long time, mental health in first responders as a whole was not addressed. It was shove it in the box.
I'd still argue
Drake
it's
more.
not still being appropriately addressed.
I agree. It's not necessarily being appropriately addressed across the board. However, eyes are on it, not only locally, but nationally and worldwide. A lot of stats have come out over the last few years. And so it's kind of in our face now a little bit, right? And so I started that peer support program 10 years ago due to personal reasons and things that I had gone through on this job, calls that I had been on that I shoved in a box, and I did not address them appropriately. And once I figured out how to wiggle out of that, I realized the need for everybody else to have access to something at the time peer support programs were just kind of starting to come around. So, you know, a lot of like what we do in education and with our stuff, a lot of research went into it, talking to other, especially larger cities. And now that I am in the position that I am within the division, I'm working on a wellness program. Again, like education, vetting programs, seeing what's out there. You know, there's expense involved as well. So we're trying to find what we can do the most for these people, our employees, while shouldering those costs and stuff and making these resources available to them. So it is an arduous process as well. And, you know, we're kind of on our way.
Just to add what Commander Wursler was saying, any program that we have, whether it's educational or mental health or mental well-being, something that we really try to stress moving forward is sustainability. You know, a lot of programs, regardless if it's at EMS or anywhere, like they'll have a real strong start initially, but then over time they'll just fizzle out and die out because they're not built to be sustainable. They're built because, oh, a grant became available and now funds are available for 2 years and you better get it in. And so what we're trying to do is build a program that will last the life of EMS is really what we're hoping for. Commander Wursler and I were just going over some numbers the other day, and we were talking about call volumes and how high they are for us. And we came up, you know, with some stats that sort of shocked both of us, and we sort of sat back and said, wow, this is a little bit amazing. And some of them were, each squad will go on an average of 190 major trauma calls per year, each squad. So we will have, on average, one major trauma call every other hour in this division, or every 2 hours. One major trauma call every 2 hours. So one of our squads is going on something every 2 hours. So like we know it's happening, and we do want to help, and we're trying to set those things up. And I know people are listening. They're like, yeah, I needed it yesterday. And we understand that, but we're trying to make sure that we can give it to them in the best possible way that is sustainable for the future. We're not ignoring them. We know it's there, and we are trying to help. We are.
I guess to those people that ask for help, right? Ask someone you trust, your partner, ask your medical director, ask me.
Yeah, right.
In fact, even on our website, we have a whole web page dedicated to mental health.
And it's
prehospitalparadigm.com.
it's
We've got
getting
resources out there.
that mindset changed, right?
Yeah.
That mindset of it's not a weakness, you know, we shouldn't be making fun of you, or, you know, yeah, we joke around in very crass ways. That's how a first responder deals with things. But, you know, it's important for everybody to have their eyes open and have a voice when they need it.
Mm-hmm. I want to add, in our contract, and you could probably, Sharon would be better at this, but it's in our language in our contract now. So there's certain specific calls where if they're pretty traumatic, you get your hour downtime, people reach out, so.
I mean, that's what Commander Wursler actually did when he was on the union board 10 years ago. Along with that peer support, we got it put into our union contract that you have an hour of downtime after. There's like 5 calls that are in there. There's a full arrest, a pediatric full arrest. There's a couple different parameters, and then it just gives the captain the ability to say, this person needs this. So it could be for anyone for any kind of call. But, you know, we are so busy that we can just take a serious call that may bother you and then take another one 10 minutes later. But you get that hour of downtime. If you still need help after that, you get so many days off, 3 days off, with the help of a medical professional. Mental health professional. You have to see the referral of the city. So in that time off, it's not just free time off. You do have to take care of your mental health during that time.
Yeah, it's EAP and a psychologist.
Yeah, because I mean, it's hard if you think about it. You get this very traumatic pediatric call. You may need to decompress a little bit, and then the next call you're getting someone's being very mean to you, and you know. So I like that was put in the language.
Mm-hmm.
As medical director, you know, my first priority is the health and wellness of our patients, but very close to, is my second priority, which is the health and wellness of my crews. And I like to think about our occupational hazards as the invisible ones and then the visible ones, right? So the visible ones are obvious. Firefighters firefighting, right? Police, like with around people who are shooting. And EMS, being on the roadside whenever there's a motor vehicle collision. But the invisible hazards, I think we're still trying to understand, right? The bunker gear carcinogen exposure to our firefighters, the PTSD that develops, even in the very staunch veteran EMS clinician. We still don't understand. What we do know is that the metrics of looking at unwellness is higher in firefighters and EMS. Obesity rates are higher, addiction rates are higher, substance misuse is higher, suicide rates are higher. And those are real national stats that we have to think about because this is a very difficult job. I myself, as a medical director, I'll say it here live, struggled with mental health in my past. And that has been very eye-opening to me to navigate that journey as an emergency provider. And I think it's important for all medical directors to recognize that, yes, we're medical directors and we're in charge with the care of the patients that we're taking care of. But very, very close second to that list is our EMS clinician, our first responder wellness. So it's definitely something I think about very seriously. My personal journey contributes to that, and yeah, everything that's going on here wellness-wise is all for the best benefit of our providers, which ultimately results in greater care of our patients.
I'll go to the next online question. With all the changes that Cleveland EMS has done, if you could redesign one part of the system today, what would you redesign? What would you change?
That's a great question.
That is.
I think just right off the rip, just doing more for reinforcing what our paramedics are already doing. So more education out in the field with them. So we're doing new stuff, right? Vents, blood, all this new stuff, but going back and just making sure that all our paramedics out there, all our EMTs out there have a good foundation and are really confident and the skills that they just learned in paramedic school or our protocol. Maybe, because putting new things out there is awesome and it's great, but just making sure that our paramedics are confident and highly trained in everything that we do every day.
So I'll have to add, if I could add to that, I think that's great. But I think what you're seeing right now is what we want. I think the leadership here, we've come through the ranks, we've been through everything as far as the field, the calls, the administration, the good, the bad, the ugly. And what we're doing now is setting the foundation for what we believe to be the future. Do we all wish it would have happened 10 years ago? I mean, yeah, hindsight's 20/20 on every bad decision that you've ever made, or look back, oh, I wish I would have, could have, should have done whatever. But the changes that we're making today, we really do hope that they set the foundation for the future. So stick around and you guys will find out.
Yeah, do some more podcasts.
You can do some more. You can be on the hot seat up here.
Yeah. More onlines?
I guess one more one. I'm asking the crowd now. How well integrated is Cleveland EMS with hospitals and med direction? I think that the fact that your med director is sitting here with you guys is a huge testament to how involved ideally a med director should be, right? Mm-hmm. So my squads know me. They've got my cell phone number. They can call me anytime. Today was a very busy day for phone calls, but I think that this is the ideal, right? Your med director is sitting here with you. But how do you guys operate with the other hospital systems?
I mean, I don't have any issues with other hospital systems. I mean,
So I think we work great.
I think,
Like
yeah, I
we
think it's
do,
fine.
we partnered up with Metro, and when we came out with the whole blood, we did reach out to all the hospital systems, and Metro was the one that said, yeah, let's do this. So, you know, our medical director at the time, Dr. Thomas Collins, and then Dr. Bates, Craig Bates also was involved in that. And then when Dr. Collins retired from being medical director, Dr. Escajeda came in. And so we partnered with Metro with their blood bank to do the blood program, and we have great relationships with the hospitals. We talk to the EMS coordinators all the time, whether it be myself or Commander Wursler, about new ideas or initiatives moving forward. How can we involve them? How can they involve us? And these are a lot of things that the field doesn't always hear from or see. So I'm glad you guys are bringing these up, because really what they just go on their calls all the time, and they work and they work and they do a great job. We have a phenomenal staff that responds to tremendous amount of calls and transports anywhere between 200 and 250 people a day. I mean, that is wild when you think about it. 200 to 250 transports a day, they're busting their butts and they're doing a great job with it. Like, our success rates on interventions are extremely high. So I'm very happy in everything that we're doing, but the things that they don't see is what we are trying to do to build the future, along with Dr. Escajeda and the other leadership, is the sustainability and involving others and getting things moving forward. I know it's hard to see those things, especially when we don't advertise them, because we are working in the background, and we don't always advertise them, because as many good ideas as we may have, some of them just don't come to fruition. And not our fault or the hospital's fault or the city, or they just don't happen. It's not the right time. And just because it's not the right time now doesn't mean it's not going to be the right time in the future. So when an idea, and I tell this to the education staff, if I tell you no, that's a no today. That's not a no forever. So keep it in your back pocket, you know, just in case that time comes up again and you could present this again, and hey, maybe the time's better for then. But we have a great relationship with the hospitals. I mean, you want to...
I don't.
Ditto.
I think you.
Ditto.
Coming to you asking for more though, right?
What's that?
So you're getting more and more of your staff coming to you asking for more. It's not just status quo. So it's like, and that shows growth too.
Yeah.
They need to just sit next to each other.
Yeah. I was just going to say, what was I going to say? Oh my gosh, I lost my train of thought. Yeah, I think we have a great relationship with our hospital systems. It's a two-way street, right? It's a two-way street with me as a medical director. I'm learning from crews all the time, and I want to have that open door policy where anybody can approach me. And that's how we generate all these ideas that are making all these substantial changes here. It's not just like a few people. It's the entire Cleveland EMS that are coming up with these ideas and bringing them to leadership that we can implement. So I encourage that. Obviously, we have to do it methodically. We have to start with a needs assessment, and does it fit our patients and what our patients need? And that answer may be no at times, and that's a tough call, but you know, it happens. So yeah.
Yeah, I think some of the best ideas often come from the people, boots on the ground, that are doing it. Comes up from the bottom, not from the top.
Absolutely, yeah.
I will say that typically when we're on our live calls, our live shows, and I'll put it up today, is typically there's a call counter that goes up. We obviously can't do that here because it'd probably be way too many for us to count. If you do 250 transports a day, that's at least 10 calls an hour, and we probably couldn't even keep track of that if tones are dropping right here in headquarters.
Yeah.
So,
If we go get a radio and turn it on, it might turn out.
no, it's all right. That's enough. So we're about 59 minutes. Any final thoughts you guys have?
Actually, I got a good one.
Oh, he speaks.
You've just been waiting for this.
I guess my question is, as a provider out in the city of Cleveland, there's two main trauma centers, one being Metro and one being UH, but they both follow different trauma protocols. Like there's Northern Ohio Trauma System, but one hospital follows their trauma protocol and another hospital follows another, and it makes it difficult providing care for somebody, knowing that this hospital will treat this person as even a limited trauma versus another hospital won't even acknowledge it and then put them in another spot until a doctor sees them. So what could we do about collaborating and making a simplified trauma system that everyone's going to get everything together for the city.
I'll defer to your medical director first, and then I'll give my answer.
Yeah, that's tough. You know, as being pre-hospital experts, we have sometimes very little control of what happens in the hospital, and we have to navigate that world and communicate our concerns with our in-hospital partners. There's no easy way. You know, we are lucky enough to have actually the ringleader of our regional protocol committee present, and so I think it starts with the group of physicians, which includes trauma surgeons, you know, in our regional protocol group, and we try to make the best patient care options for the most amount of EMS and fire agencies in the region. That also makes the trauma surgeons happy about their patient outcomes, and that is difficult. And there's never going to be like a single quick like algorithm that's going to satisfy everybody. So continue to navigate that space. I don't have a great answer. You know, I can't control what some hospitals do. I can complain about it, but it doesn't mean anything's going to change. And that's okay. And you know, and that's the way it should be. So we shouldn't control, you know, what happens in the hospitals, just as like the hospital shouldn't control what happens in our world.
Very well.
So you guys have 2 trauma centers here in my region. We've got 3. Take that back. 4. So 2 level 2s and 2 level 3s. Each of them have their own criteria. Obviously, ACS sets their criteria for what full trauma level 1 traumas are. They're obviously sick. No one's going to say no to those. Right. And then typically there's going to be another level behind that, if not a second. My advice, I'd tell all my crews, because they're transporting into 4 different systems, don't memorize them. Just advocate for your patients. Say, I've got a high-speed motor vehicle collision traveling 55 mile an hour on a highway. There's a large amount of front-end damage. There's intrusion 24 inches into the passenger compartment. Airbags deployed, seatbelts were on. Patient was restrained, but GCS is 8 and we're intubating on scene. I mean, that tells you the whole story right there. Just paint the picture on the phone on when you're calling that pre-hospital report, and it's really on that receiving hospital to make the calls to what level to activate that in mind. And then advocate for them. Say, hey, I request a trauma team. Here's what's going on. And they should listen to you. But that's the best thing you can do, is just don't memorize what their criteria is. Just represent how your patient presented. Give that history of what happened. What was the mechanism of injury to make me decide what I have to activate on the hospital side to prepare for your arrival. That's a great question. All right, so wrapping up here. I got distracted. First, I want to thank you guys for having us here. It's been a fantastic conversation. I am going to pop up that dodgeball tournament back on the screen for everyone to see.
So you can get a team. It's $250. It's so much fun. We have raffles and.
What's the location?
It is at Mulberry's, 2316 Mulberry Avenue in Cleveland, Ohio. I'm sorry? It is May 30th. Registration's at 10 a.m. and playtime starts at 11.
And that goes to benefit your peer support
Goes to
program,
benefit
correct?
our peer support. Correct. Yes.
Yeah, plug away.
So part of our, not to get off topic here, but part of our whole blood program is coming full circle and giving back. So we've organized blood donations every 56 days, I think it is, throughout the year right here at EMS Headquarters. We partner with Metro for our blood, and they get their blood from the Red Cross. So the Red Cross is coming in here. And our next one, I believe, is May 23rd. And if you come and donate, you get a free Cedar Point ticket.
Ooh, that's
awesome.
nice.
That's awesome. Good for you guys.
Yeah. If anyone out there is listening, absolutely. If you can donate, please donate blood. Everyone needs it everywhere.
Is there a specific type you would like?
I know. We want all types.
Oh.
We need all types.
Yeah, we need all types.
I know we do.
The big push right now is low titer O positive, whole blood. So young men, especially that are healthy, come get a Cedar Point ticket, and your blood might be on a truck near you.
Yeah, so we've got, if any of you are interested, we do have a whole podcast on blood, talk about different blood types. O is super helpful. AB is super helpful. A by itself is actually super helpful because it's the most common blood type, A positive is. So if you're interested in blood, go listen to that. But we'll take anyone's blood that we possibly can. There's chronically shortages throughout Northeast Ohio and the whole country. I kind of plugged it earlier for us. We have our website, prehospitalparadigm.com. That's where our show notes are for this. You can look at all the videos and audio links. I'll put a link up to your dodgeball thing.
Great.
We'll post that
Thank
in our
you.
Facebook also. And then our final plug is to FirstNet and Cradlepoint. They provide us cell service and equipment to allow this to be broadcasted out to all of you. Thanks all for watching, and hope everyone has a wonderful night.
All right. Thank you guys for coming.
Thanks.
Thank you so much.
Thanks for my audience.